know, at least a teaching case that you should know. What I want to show you now is I want to show you how you can actually assess the origin of mitral regurgitation. This is a patient, I guess not difficult to detect, who has a problem with the mitral valve, right? Take a look at the mitral valve. You see the texture of the mitral valve. Here is a 4-chamber view. Right here you see how thick the valve is. Okay, here we did some measurements. And this is a very nice view because here you see the exact cut plane where we see the problem. This is a mitral valve prolapse. I think all of you have noticed this. It's a typical myxomatous mitral valve, or we also call it classic mitral valve prolapse, where we have redundant tissue, where we have prolapse of material into the left atrium, where we have so-called rocking motion of the annulus. And these patients frequently progress to more and more myxomatous degeneration and to more and more mitral regurgitation. So this is a typical patient where I would say she will have problems in the future if she does not have it right here, right at this time. Just a side track, because this is something that just kind of startles me. There was a recent article which was published, I think it was in JACC, or can't remember, I think it was in JACC, and they studied patients with mitral valve prolapse, with severe forms of mitral valve prolapse, and they found a subgroup of patients who were actually at risk of sudden cardiac death. Now, I truly believe that in general, mitral valve prolapse patients should not be afraid that they will just drop down and die, but I know that there are a subset of patients, and I've seen them myself, who do have severe forms of ventricular arrhythmias. And I'm showing you this image loop because this can kind of help you explain why this is so. Look at how this prolapse kind of tears on the papillary muscle, and thereby you have you know, kind of a very rigorous motion here on the lateral or posterolateral wall of the myocardium. And if you go into histology, and I've seen very beautiful images of this, you will see fibrosis and all sorts of different morphologic abnormalities of the myocardium, which could be a focus for arrhythmias. I know that some patients actually lose or have less ventricular arrhythmias after they're operated. So there's just a connect between myocardial function and mitral valve prolapse. But I guess I just got lost with what I was going to say. But coming back to actually the topic of this case is origin of the jet. Now, there's certain ways of detecting or finding out where the problem really is. One of the easiest things to do is if you just perform a short axis view of the mitral valve. This is massive thickening of the mitral valve right here. And then you place the color Doppler in here. Okay, I'll do this right here. And if you put color Doppler in here, you will be able to see the origin of the jet. Now, you will not be able to really determine how severe regurgitation is because you cannot really see the length. But you can see the origin very nicely. And if you look closely, you can realize that the jet is coming right here from the posteromedial commissure, right? Posteromedial commissure. Why do we know it is the posteromedial commissure? Let me go back to the presentation and just show you this image here. Now, if you look at this, this is the way we image the mitral valve. Those are the different cut planes. And if we have a short axis view here like this, you just have to kind of turn it on the side. You have to turn it 90 degrees. Then we have the anterior leaflet, which would be on the top, and the posterior on the bottom. And then we have the commissures here and here. And the posteromedial commissure is to the left of the image, and the anterolateral commissure is to the right. And then adjacent or close to the anterolateral commissure, we have the section of A1P1. This is the Carpentier classification, which I guess many of you are familiar with. This is the mid portion of the valve, and this is the posteromedial or medial portion of the valve. And if I go back to now the presentation again, to the image, you see that this here is the posteromedial commissure, this is the mid portion of the valve, and this is the anterolateral portion of the valve. And if you look at a two-chamber view, you can do the same thing. This is the two-chamber view, and here on the side would be the anterolateral part. This would be the medial part, and this is the posteromedial part. So 1, 2, 3, with the commissures right here at the end. And all you have to do is put your color Doppler in again. And again, you will see that the jet comes here right from the posteromedial aspect of the mitral valve. Okay, so this is, I think, quite nice to see. Remember, in this view, you cannot determine if you're seeing the anterior or the posterior leaflet. You're cutting way across the commissural line of closure. So you're cutting down right like this. So you're neither there nor there. You're right in between, unless you kind of have the transducer a bit more to this or this side. But you cannot differentiate between the anterior and the posterior leaflet in general. So by using this view and the short axis view, it's easy to tell where the origin of the jet is. And then finally, there's a third way of doing it, and that is by simply using a four-chamber view. You start out with a four-chamber view, and what you do is you first start out actually with a view where you have part of the aortic valve within the image. If you have the aortic valve within the image, you are cutting right here. This is the aortic valve, and you're cutting right here through A1, P1. So this is the part of the mitral valve you're seeing. So it's kind of a five-chamber view. There you're seeing this part of the valve. Let me go back to this, right? This is the part of the valve you're seeing. And then you just put your color Doppler in. And then you see if you're able to detect mitral regurgitation. Now, don't look for the jet. Look for the origin of the jet. Look for the flow convergence zone, which you do not see here. So this is not the origin of the jet. Next, you move the transducer down, or slant the transducer down so that you have a typical four-chamber view. And now we're cutting right through here. Okay, this is the view you have now, and we're now crossing A2, P2. We're in the middle of the valve. What do you do? Use color Doppler. Okay, here we do have a bit of flow, more than we did before, but again, we do not really have the typical flow convergence zone that we're looking for. And then after that, the next thing you do is you move the transducer even down further. Now you have the part of the valve where you actually see the coronary sinus. You see there's just a short frame or so where you can see the coronary, here, right here. You see this here? This is the coronary sinus you're having here. So it means you're right at the bottom of the mitral valve. Let me go back to this again. Now you're cutting right down here. This is the coronary sinus. And now you have this part of the valve right in here in your field of view. And if you use color Doppler, right here. Now this is the maximum portion of the jet. So here you've again detected which part of the valve is leaking, and it is the part P2, A2, posteromedial commissure. And going back to the 2D image, this is also where you have most of your myxomatous degeneration. So tell your surgeon where the origin is. It will help him in planning the surgery, and it's kind of neat to put it on your report just to show that you know more about the morphology of the mitral valve than many other people do.